welcome to our session. We are from the Netherlands, so I apologize up front if we say something completely different or the meaning is different. That's hopefully not going to happen. My name is Brouwer. I am currently chair of the Dutch Association for Physiotherapy in Lymphology and Oncology. But long ago, I started together with Ad in the Nijsmelingen Hospital, which is in the north of the Netherlands. Nowadays an expert center, which Ad will explain you more about. And I'm consultant for companies who do something in compression therapy. And I travel the world educating people about medical background, the use of compression, and self-management. And self-management is something Ad and I are specialized in, teaching also health professionals as well as patients in the past. But the real specialist is Hendrickx. Ad,
well,
your turn.
Pressure is high. I'm a physical therapist by background, and indeed I work in the Center of Expertise for Lymphovascular Medicine. We see the most complex patients with lipedema, lymphedema, chronic edema, wounds from all over the Netherlands, and we also have a role as European reference network for primary and pediatric lymphedema. I'm curious who you are, and I would like you to shortly introduce yourself, your background, and especially whether or not you agree with our title. Self-management in chronic edema, is it wishful thinking, or is it a definite need for the future, or perhaps a combination? So may I start with you?
Everyone's heard this before. I have no clinical background at all.
I know.
I'm just here really as an observer. I'm looking tomorrow and I'm joining in the workshops, but learning a lot from it.
Yeah.
So
And thinking about the title? Okay. Feel free. Any answer is fine. There are no stupid questions anyway. I continue.
Yes, I'm Jo. I'm a lower limb specialist nurse. So primarily we look after patients with leg ulcers, but there is no lymphedema service in our trust for patients that don't have cancer. So we see a lot of the lower limb edema patients as well. And yeah, it's a definite need for self-management.
Okay, good, thank you.
Hi, I'm Emily. I'm a tissue fibrillity and lymphedema nurse. Yeah, I think it's a definite need. We're always looking at ways in our clinic how we can promote self-management. I think the level of self-management we want might be wishful thinking, but yeah, we're doing lots at the moment around self-management and promotion of that.
Yeah, thank you.
I'm Rachel. I'm a foot health practitioner. I work in private practice. Been doing that for about 18 years. And yeah, I think there's a role for the person to be involved and professional as well.
I'm Jack. I'm actually happy. I just filmed in today and I work for Hendrickx, so I have years of delegate at the moment.
Okay.
So,
And have you an idea about?
Yeah, just through obviously I work in the marketing department, so just through bits and bobs and stuff. So yeah, I was interested.
Hi, I'm Maria, Marie Poole. So I was a tissue fibrillity nurse for years, and now I'm a clinical consultant supporting the Leg Club Foundation. And I absolutely think it's needed self-management. It needs to be collaborative. Patients need to understand their responsibility within managing it, that it can't be done for them.
You already introduced yourself, but perhaps.
Yes, I will introduce myself. So I'm Claire Meach, and I'm Leg Club ambassador and also nurse manager that leads Leg Club. We've been running for 10 years down in Poole in Dorset, and absolutely I think self-management in lots of areas is a definite need for the future. I don't think it should be wishful thinking. I think it should be encouraged.
Okay. The model we are going to present is a model useful and usable in chronic conditions in general. So it's not specifically for chronic edema, but I think using the model now for several years, it really helped us in our center to optimize really personalized care. And it's still work in progress. Let's be aware of that. New colleagues have to be introduced, but we also, it's easy to re-fall in, well, let's say, old habits. It's challenging to stay tuned in using new techniques, adapting new possibilities. This morning we discussed COVID, and in COVID time we were forced to change, and we were able to change, and in many cases we re-fall into older habits, older ways of treating and guiding patients. We're gonna use some slides.
Yeah, we did have payment for our flights because the association is not very rich, like many associations around the world. So we're thankful for that. In the Netherlands, we have a reasonable good healthcare system. We pay ourselves around 160 to 200 euros a month from our salary. There's also a threshold of 385 euros when you go into a hospital. That's what you have to pay yourself first before the reimbursement starts. That's going to increase next year, not the 385 euros, but the amount we pay on the insurance ourselves is going to go up. So soon we will go over the 200 euros that we have to pay from our salaries. Then we have, of course, access to a lot of good care. It's getting worse. Also, we experience much more cost cuts, a lot of problems in getting the right doctors. We're getting doctors, nurses, physiotherapists from abroad, which our government is not agreeing with at the moment. It all depends on which government you have at the time. But we have also our issues, although we cannot complain. Comparing it to the NHS, for instance, which is already broke, I believe, for many, many years. But the challenges are also in mainland Europe. These papers show, on the one hand, that you want to have the availability of affordable healthcare. On the other hand, we have the problem with getting all the staff, the right staff in the right place. But you also want to give everybody equal healthcare possibilities. And that's a challenge, I think, at the moment.
That's challenging, and we see, and that is illustrated by the two hands and the heart. One of the basic principles of the Dutch healthcare system is that of solidarity. Every person is equal and should be able to get the same kind of high quality care. And in society, the discussion raises, why should I pay the same amount of money as my neighbor who is not exercising, who is drinking, who is smoking, who is obese, with high risks of chronic conditions and worsening of chronic conditions. So that discussion is rising, and we are facing the challenge to deal with all these items, rising costs, more patients, less staff, and the feeling of solidarity is decreasing. And that's what we are working on. I think the Dutch government states and underlines a huge ambition.
It's a real good high challenge, I think, that in 2040 all citizens live at least 5 years longer in a healthy state. Well, what's the definition of a healthy state? That's one. And the second one, of course, is how are we going to measure that? But I can explain that. I think the disease burden caused by an unhealthy lifestyle and unhealthy environment has been reduced with 30% in that time. I don't know what the discussions are here, but we're talking about a lot of things that have to improve in nature. Farming has to decrease, a lot of things that we have to do to ensure that we still have a good health in 2040. At your...
does the English government has same kind of ambition?
Yeah.
I think there's more focus on lifestyles. I'm not sure that they've actually called it out as clearly as that in terms of its impact on health.
Yeah, absolutely. An unhealthy lifestyle is strongly associated with healthcare costs, with healthcare outcomes, with an increase of the chronic conditions. So yes, this one is very important. And for me as a healthcare professional, this ambition is very helpful. Because, and then we go to the next slide, it
pushes you in a direction.
Pushes us, but also patients, citizens, let's call it citizens, into a direction where the local governments have to organize a healthy environment. An environment where it's inviting to walk, to bike, the bike paths should be safe. Walking facilities should be there. The McDonald's are not allowed anymore at any corner of the parts of the cities with the lower incomes. That's what's happening now. The McDonald's are the only restaurants along the highways. The other ones are disappearing. So that's local and national policy which has to enable that.
And it's not that far yet,
Yeah.
so don't
Yeah.
think that we're already there, because McDonald's is still rising, and not only McDonald's. But I think it's also from the insurance companies. We have health insurance companies that motivate if you move. If you do a moving program or you're a member of some kind of club, then you get a discount on your fee. Or you get other advantages. Do you have that as well? In moving programs or non-smoking programs?
There's a company called Vitality Life, and they give you, if you go to the gym, you get lesser premiums, and they give you lots of incentives.
Okay.
But not many companies, only for private. Yes, but they're the only companies that that's not for the NHS, it's only for those that can afford private health insurance.
And those who usually already go to clubs.
And of course, in the UK, there's not a lot of people who've got private healthcare because they've got the NHS. So
This is actually life insurance, not healthcare.
Yes.
So if you don't have a mortgage protection.
Oh, yes.
Health insurance.
But also the ambition pushes us in general, professionals and patient citizens, towards that you first rely on your own talent. What can you do by yourself to live a healthier lifestyle? And if you don't succeed by yourself, by your own talent or limited talent, what can your social environment do? Including the local policymakers. And the next step is technology, sensoring, thinking about smartwatches, the sensors for diabetes, but also tools as making pictures of a wound, sending it to the GP. That's already existing, but we are still stimulating to use that more and more. And after that step, just then medical support comes in. So it's a model of stepped care in which medical support has to be flying in at the right moment, but not too early. First of all, what can you do by yourself? We are pushed in a positive way, in my opinion, in that direction by these policies.
And that's about self-management. Well, dealing with symptoms, emotions, treatment, lifestyle. I think some people are fed up with hearing about lifestyle because everybody's talking about it. But we have no choice because we have to change. That means that you're in control of your own life, of your own disease management. Know what your body needs. I think most of us can indicate ourselves what we need. Sometimes if we're doing workshops all day, you want to go out and move. We already decided we go in between the dinner and now we go for a walk. Make healthy choices. Doesn't mean that you have to do that every day. I even stated to the last group, we had a muffin yesterday when we arrived because we were so hungry, and you want something typically English. Maybe we should have taken something else then, but we deal with the symptoms step by step. It doesn't have to be all at once. And work together with your care team. It's not about, and next slide, about letting people go on their own. We don't throw them off a rock. It's not self-management, although the word self, of course, implicates that you have to do it all on your own. You have to figure everything out without any help. That's also not true. And that's what you use, especially in your practice, Atte, that you tell people or talk to people. It's not what it is, but what it isn't.
What are your when you are talking with your patients about self-management? What's their primary reaction? Is there a primary reaction? And do they say, "Oh yes, I want to do that"? Depends on the person. That's true.
Yeah.
But what do you hear often, or?
They're like worried or anxious about what they're having to do themselves without being overlooked by a healthcare professional.
The safety net.
Yeah. I reckon that, and I get those questions less using
If you
also explaining what it is not.
Mhm.
That you have to do it all by yourself.
Yeah.
And that it's a replacement for medical care. No, it's not. It's about medical care, medical support at the right moment, at the right time, at the right place. That's what it's more about.
Yeah. And it's just not just that they have to push through. You have to, of course, do it step by step. Okay. So self-management is effective. We know that from many studies, also coming from the UK. I think Australia had already a lot of self-management clinical evidence. I think all kind of chronic diseases like COPD, diabetes, etc., benefit from self-management skills. I think that's not new. That's not also not.
But also important, positive impacts on quality of life. Sometimes patients in advance are a little bit scared or a little bit, can I do that?
Do that, yeah.
But finally, it creates these kind of effects. Also in chronic edema, there are already some studies in lymphedema.
Yeah. So self-management support involves a patient-centered collaborative approach to care and enhances patient self-management by promoting patient activity. That's what we do together in the Netherlands. So insurance companies, the hospitals, physiotherapists. That's why as an association for physiotherapy we work closely together with the center outworks with, but also with skin therapists we have in the Netherlands, and also with patient organizations. Like I think the initiative of the Leg Club would also really fit into our structure, because you have to do it together. We also have the Dutch lymphedema framework now. It's part of the ILF, which you all know, I think, which was born in the UK, where we look together at lymphedema, lipedema, and everything in between. Self-efficacy is very important. I think that's part of education and empowerment. But education is something that we do literally from the start of the treatment until they leave, and we offer enough afterwards as well to make them aware of what is possible.
Well, and we are aware, and that's where the model comes in, I would like to introduce to you, that one size does not fit all. It depends on the patient, you said. Yes, it does. And is every patient suitable for self-management? That's a question to you. Not all of them.
Not all of them. No. There's so much that they can do themselves, but sometimes they're not physically able. But there's always a little bit of something.
Yeah, they can do. Lieke van Houten did, I think, great research, and the second sentence is, I think, of important. The knowledge lacks of how to support patients, but that knowledge lack leads to results we don't want. We spend too much time to patients who don't need it, probably don't need it that much, and that's why we have too less time for patients who really need it. And how can we differentiate? A question: your follow-up scheme, perhaps you have had an intensive treatment phase, and the edema is under control, or the wound is healed, or is getting better. How do you decide when your patients get back, or how do you decide how to support those patients in the future?
Is there a fixed schedule, or do they have to come back every week or every?
It depends on the again. That kind of depends on the patient and what they can what they can do themselves. So you might see someone next month, or you might not see them for a year, depending on where I am anyway.
I think you said literally at the end there, where I am. There's a lot of variables, isn't there?
Yes.
Because probably sitting around this room, we probably all have different policies, procedures in place, so it will be very variable.
We're moving more towards PIFU, so patient follow-up. So where I used to chase patients, put it very much back in the hands of the patient, how to contact us if it's suitable. It's not suitable for everyone, is it? But it seems to be working well.
With introducing this model, and we call it Sjaak Bloem is one of the developers. The SHE model, SHE stands for Subjective Health Experience. It gives us extra information as healthcare professionals to discuss with our patients what kind of support do you need in the future. How can we help you to optimize your self-management behavior, your self-management skills? Jacques Bloem is from background a psychologist and health economist, and he is professor at the business university, and his main goal in his professorship is sustainable healthcare. So how can we create a healthcare system which is affordable and offers high quality care guaranteed for the future? The model is usable in, let's say, all kinds of chronic diseases, so not only in chronic edema. There has been research already done in an AIDS population, in a rheumatoid arthritis population, irritable bowel syndrome, so a variety of conditions where the model is tested. And I'm going to explain it shortly. I end up with a QR code with information, or with a link to the website of our hospital, with an English version of the model, background literature, and also a poster on it we created for an international conferences where we explain both the model and some research we performed.
And we, at least Ad chose in his thesis he has finished last year, is to use cartoons instead of difficult language. And one of the outcomes of many research is that too much text or too much difficult language, medical language, is not helping the patient population either. So a nice way of communicating through cartoons. In real life, the cartoonist told me that cartoons are not fashionable anymore, or they're outdated. So it's nice that we can use it now in the medical world.
Yeah. Mm-hmm. And perhaps we are gonna create some TikTok movies
soon. Yeah.
I do believe in one of the aspects of the SHE model is that it's a PROM, it's a patient-reported outcome. On the one side, we have the biomedical outcomes, like wound circumference, volumes of the legs, blood values. Those are hard biomedical outcomes, and PROMs are more the patient-reported outcomes. You measure subjective health by asking your patient on what position on the ladder are you. Lower steps illustrate lower experienced quality of life, and higher steps create higher experienced health. Experienced health is based on two psychological constructs besides the biomedical outcomes, and the constructs are acceptance and control. Illustrated by the backpack, a big backpack, high control, high acceptance. But what's important in relation to self-management, that it correlates the position on the ladder with self-management behavior. You can understand that when you are in control and when you are accepting your condition, you are more willing to work on by yourself on your health condition to maintain it or to improve it. A little bit theory and then to you. Acceptance means, can I give the condition a place in my life? Can I accept that I have limitations due to my condition? That's not a fixed point. It's not, I accept it and it's always there. That will always, I think you recognize that, fluctuate. So repeated measurements are useful in tailoring care. But acceptance is an important construct, and you ask the patients 3 questions, score them, and finally you can create a total score which helps us segmenting patients.
But you started with 12 questions, which was too much.
I think 12 or 15.
You eliminated it.
Yeah, we try to make the tool as small as possible. And what we see in our patients that they are really willing to fill it in and also periodically fill it in.
But rather than all the big questionnaires that we all receive, I think, on a daily basis in your mailbox, also patients are fed up with filling out all these questionnaires. So this is a simplified version, which is acceptable.
Yeah. Control, do I have influence on my conditions? Can I influence it? That's the second main psychological construct. And what you finally can create is segmentation. You can create 4 profiles of patients. And segmenting or profiling is, of course, a limitation of reality. Creating a model, thinking in a model, simplifies the real world. But it helps you to think about what kind of support can I offer this patient. And of course, you discuss that with that patient. It's always about shared decisions. It's not that I measure, oh, you're in segment 1, high in control and high acceptance. That means that you are gonna be seen in a very low frequency and you only get an email once in a while to inform you. It's always in dialogue.
Can you relate to this 4 pictures? 4 groups, which population, in which category would your patients fit? Are they very well educated, high income, intelligent Dr. Google patients, or do we have the low control and low acceptance group?
Some of them all.
Some of them all. That's a nice mix.
Yeah.
And I guess depending on where they are in their life, they go between
Sure.
and up and
Yeah.
down.
I fully agree. At the same time, there are good data which reflect, anyway, in the Netherlands, the mean
Averages.
averages of a healthy population. They asked 2,500 persons, where are you? Is your level of control? What's your level of acceptance? Do you have any idea how the distribution would be? Equal, all 25%, or?
In the country,
Yeah.
nationally.
A lot in low control, low acceptance.
And why do you think so?
That's what I've experienced in my clinical practice.
Okay. This was the normal distribution in the Netherlands, anyway. That at about 32% was in segment 4, low, 32% in segment 1, high, and the other ones in between. If you do the same questions in an oncology population, you see another distribution. Of course, 50% is low in control and low in acceptance, not surprisingly, probably. Psychiatry population, 53.5. We have a tertiary referral center, so meaning we see the most complex patients who have been elsewhere and not succeeded in their therapy or in their diagnostic process. But when they come in at our center, 70% is in low control and low acceptance.
And that was different when we started 30 years ago. We saw much more lymphedema patients, and now you see a lot more lipedema patients, obesity-related lymphedema, and some people with lymphedema who cannot find the right treatment. So it has shifted really to a different population.
What we prepared for you, and the papers will be present tomorrow, also one of the last slides. But when you would consider in using this model, you could ask yourself in 3 steps some questions. The first step is, what is the profile of your patient? In what segment is he, and what kind of behavior does he show? What kind of language does he use? What kind of questions does he or she has? What kind of needs? And you could, as second step, think about what kind of care do we offer at this moment? And based on this model and based on these profiles, should it be an idea to change it? And in what segment would that support be placed? For example, this is one of the papers we developed. For example, if I ask you now, patient in segment 4 with low acceptance and low control, what is their experience? What is their behavior? What do they tell you? How do they come in?
What do they expect from you?
Yeah.
To solve the problem? Or to, in general?
Yeah. What can you do for me? Do they come in with a question, what can I do by myself? No.
Just to share with you, when I was a tissue viability nurse, I had a student district nurse and did some time with me, and she was doing her degree at the time. And for her dissertation, she was doing a piece on malnutrition and its effects on healing venous leg ulcers. But one of the questions that she asked her patients was, whose responsibility is your wound? Is it yours? Is it yours and the patient and the nurses, or is it the nurses? 96%
Yeah.
said it was the nurse.
Oh,
Yeah.
wow, yeah.
Exactly.
That's
That
fine.
kind of
Yeah.
reflects on
Yeah.
us as nurses,
Yeah.
doesn't it? Because
Yeah.
we're given that message, or we
Yeah.
were
Yeah.
given that message.
Yeah.
The question, what can I do for myself, will not be asked by this segment. The patients in segment 1, high control, high acceptance, will ask you that question.
Yeah.
So also need another kind of support, need another kind of answer, need another kind of guidance. If we shift towards patients with low acceptance and high control, what support do they benefit most of? Low acceptance, high control. What did you say?
Education.
Education? Yeah, I think so. Education is always of importance,
Yeah.
but education primarily improves control. I know what I have, I know what I have to do. Does education influence acceptance?
They understand
Yeah.
what's happening to them,
Yeah.
how to understand what needs
Yeah.
to be
Yeah.
done and accept
Yeah.
what
Yeah.
needs to be done.
So by the route from knowledge, control, perspective, acceptance, yes, I think so. But patients with low acceptance benefit most from understanding, empathy, and information not from you, but from fellow patients. Peer support, yeah. So consider, if you have many patients in that group, high control, low acceptance, consider to work in groups, to let patients meet each other, discuss with each other. And of course you will have to control in some way what they tell each other. But I also do a lot of oncology rehabilitation, and the most beautiful things happen in the dressing room after the training, where patients meet each other, talk to each other, and come back. But I always ask the next time, well, did you discuss anything in the dressing room? Because I want to be aware what happened there. I want to be a little bit in control. But peer support from fellow patients is very important and very helpful in that group. And thinking about the first or second slide, about the limited number of staff available, consider including, in the University of Leuven really includes in their treatment patients who are trained to train other patients, to guide other patients, and it works very well. And patients are eager to do it.
Absolutely. We need to go to the next slide.
Yes, we will. This is, I think, a nice summary from the experience from patients. This is research. The characteristics, so some demographic aspects are included. And not surprisingly, patients in segment 1 are frequently relatively young, have high level of education and income. And what do they need? Personalized information. This is the group who comes with information from Dr. Google, but in some cases very adequate.
Yeah.
So our role is to guide them to adequate information and to help them find it.
Using ChatGPT and all these things.
In contrast
not
to
correcting
the
it.
to the group, and by limiting the amount of visits of this group, you can this group more time. And the data of this research allowed me to discuss with our management team that I need more psychologists and social workers. And it also enables me to discuss with the reimbursement companies that there is a group thinking about 30% of the normal Dutch population is in segment low. So we won't be able to optimize self-management in all patients. So it allows me to discuss with the reimbursement companies. There is a group of patients who I have to see on a more frequent basis as others. But now they even want to skip that group, which I want to see regularly and follow up. So it gives me more tools. I hope it gives you more tools. We do it, of course, it's not, this is your profile, this is your guidance. It's always in dialogue, it's a shared decision. And we use this praatplaat in Dutch.
And praat is for talking in Dutch, and plaat is poster. And together with Claire, we're going for the English word.
Well, we called it a snapshot.
Shots, yeah. So this is available tomorrow on paper, but also digitally if you want it.
Yeah.
You can email us. Where do you use it and how do you use it?
We use it in our conversation with our patients. And we evaluate it on a regular basis, especially in the intensive treatment phase. Patients can score their position on the ladder today and the last months, the mean of the last month. You can discuss with the patients what do they need to get higher up the ladder, to get more control and acceptance. And you can discuss what are we gonna do. So finally you come up with a therapy plan with responsibility for the patient and for me or for our team. And if patients are more into words as into figures, you can also ask them to describe their best day and their worst day. And sometimes patients write, well, on my best day, I like to walk with my grandchildren to the park. Well, that's very illustrative for that you really can set personal goals and discuss the own contribution of patients. And
we realize that it's not always easy to implement one of these new models, but it did give you in the end a lot of space and time to spend to the patients who need more time.
We thought we offered rather well personalized care. Using this model we realized it can always be better. Yeah. This is the QR code to the website of our organization.
And the paperwork will be available tomorrow. We'll leave it at the reception when you book in, and you can pick up a copy tomorrow.
And we're still there until tomorrow afternoon.
Thank you.
Thank you very much.
Yeah.